I'll try in the next few minutes to answer the question if we can really predict early enough through endocannabinoids the time of delivery in high-risk women for preterm birth. First of all, I'll just run quickly through a few information that we're all aware about. Preterm birth is birth before 37 weeks of pregnancy, and it is quite common because 10% of births are premature. Now, it has serious long and short-term consequences. The tests for prediction are not always available in our hospitals, and are not, even if they are available, they're not always reliable. I'm not going to go through the etiology because it's quite diverse and endless. But what I need to point here is that the management so far is mainly tertiary. Things have already started happening, and more or less we're dealing with the situation. Now, the reason why clinically preterm birth is important is because 75% of perinatal mortalities are in premature babies. So as you will notice here, the more the gestational age goes on, the lower the mortality rates. But even those babies who are lucky enough to survive, you see that half of them will end up with long-term medical conditions, either respiratory problems, cardiac problems, developmental problems. So if you think of the preventive tests that are available are either in the form of ultrasound, measuring the cervical length, which is quite debatable if you can use it in low-risk women. The thing is that when the changes happen again, that means it's a little bit late. And in the current practice, we use it in combination with the endocervical swabs, either in the form of fetal fibronectin or insulin-like growth factor binding protein 1, commonly known actin parters. Now, these tests are done mainly on symptomatic women before 34 weeks. They are very good if they are negative, but if there is positive test, the chances are 50-50. And the problem is that we end up with a lot of false positive results, okay, either because of maternal blood, amniotic fluid, semen, or gel, and unnecessary management and anxiety. So the question here comes, what if we had a test that would tell you which woman could leave the hospital and go home and carry on with her pregnancy, and which woman should stay in the hospital because she's going to have a baby? And here, I'm going to shift to the endocannabinoids issue. Endocannabinoids is the natural cannabis that our bodies produces. They are lipophilic unsaturated fatty acids. They're found everywhere in our body, including the blood. Now, the most commonly studied one is anandamide. Anandamide is not a scientific name. Ananda in Sanskrit means bliss, happiness. There are two less popular in literature endocannabinoids. I'll call them OEA and PEA to make our lives easier. The reason why we were interested in the other two endocannabinoids is because they are involved in what we call entourage effect, which means they prevent the destruction of anandamide, AEA, and they enhance its activity. So in a way, you would expect in our bodies these three endocannabinoids to be high or low, more or less at the same time. So previously, a group has shown that AEA, anandamide in pregnancy, tends to fall on the second and third trimester, then gets higher during term non-labor, and very high during term labor. And then a similar study, but on the same cohort of women, showed that at term, before induction and after induction, there is 1.5-fold increase of AEA. So the same group did a pilot study to see if AEA would increase in women who were at high risk for preterm labor. The idea is if it increases earlier enough. And of course, it was a pilot study, but the results were very promising, considering that it gave us a sensitivity of 100%. So it suggested the risk of 2.88 with high anandamide. So the objective of the study initially was to answer the question if AEA can really predict preterm labor in high-risk women. And that would be achieved by measuring the plasma AEA and OEA and PEA, check the predictive values, and do the cervical actin parters and cervical length for comparison. Now, the approach was approaching high-risk women from 24 to 34 weeks, either from the antenatal clinics, wards, labor ward, do the swab test, do the ultrasound, take the blood, and see when they were going to deliver. Now, the results initially, in fact, the first results that were presented last year in BMOGs were from the first 51 patients, 18 from the clinic and 33 as emergencies. we took the plasma, we analyzed it through a mass spectrometry, and anandamide values were quite higher in women who ended up with preterm birth. I mean, visually you can see also with OEA and PEA the values are higher, but they were not statistically significant. That's possibly because the numbers were not big enough at that time. Then a second objective came up. What if you can examine if the plasma levels can predict a risk-free period, a time to delivery interval, okay? And during this period, at least if we know that we're safe, we can prepare for primary prevention. So the principle was to compare the endocannabinoid levels depending on the recruitment to delivery interval. Do multiple comparisons for each endocannabinoid, okay, based on the cutoff point of 8 weeks, before 8 weeks and after 8 weeks, before 9 weeks and after 9 weeks, before 10 weeks, and the same way for all three endocannabinoids, see if there is any significant difference and what kind of conclusion we can get from there. So when we did it, for example, with a recruitment to delivery interval of 10 weeks, we saw that women who delivered within 10 weeks of the test had higher AEA levels than women who delivered afterwards. And the same result was with OEA, even more significantly, and the same was with PEA. When we analyzed only from the women who were recruited from the prematurity prevention clinic, again, the 10-week interval as a comparison was quite statistically significant, rather than 11 weeks. So when we plotted all the data together, all the p-values, you see that almost at 10 weeks, all three endocannabinoids showed difference in women who delivered sooner rather than later. And there was this kind of a pattern that around this time is that something is happening, the changes happen. Then when we did the same plotting from the patients who were recruited only from the prematurity prevention clinic, yes, even though there wasn't significance with the AEA and PEA, it was still around 10 weeks, and still with the same kind of U-shaped pattern. Initially, we said we recruited from 24 to 34 weeks. Okay, so what if we do the analysis on women who were recruited up to 30 weeks of pregnancy? Again, the similar pattern. So this 10-week kind of risk-free period is more or less around there. So you could say, with this preliminary data, that endocannabinoids can predict labor up to 10 weeks in advance. So we don't really need a crystal ball to tell you that you have 2.5 months of safety. Now, as a conclusion, we could say that endocannabinoids predict which women will end up with preterm labor. And all three of them can tell you, okay, if women are symptomatic, they're going to have preterm birth. But in asymptomatic women, it was only OEA. And we're talking about roughly 10 weeks. The clinical impact is that the swab tests have 2 to 3 weeks prediction rather than the blood test that is 2 months. So you can imagine how cost-effective such a test could be. Of course, this was based on a relatively small cohort. So our recommendation would be, first, to recruit more women, okay, to say these results more confidently about all three endocannabinoids, and then do a large multi-center study for women between 24 to 27 weeks, okay, and by multi-center, it could be all over the United Kingdom, or even Europe, or all over the world. At this stage, I would like to thank very much my supervisors, Professor Justin Congi and Dr. Anthony Taylor, and the women who participated in the study and participated afterwards as well. And I will be happy to answer any questions. Thank you very much.